Thank you for the invitation. And I'm glad to be able to dive deep into this controversial topic. These are my disclosures. We're all aware that a third or a fourth of psoriasis patients develop psoriatic arthritis. And there is a latency period for about 7 years that gives us a window of opportunity for intervention. And the onus of that lies on the shoulders of dermatologists. The goal for all of us is to move beyond treating established joint damage to preventing it. And we all hope that early targeted intervention can reverse or halt the disease progression. So this figure represents the various stages of psoriatic arthritis. The first is the immune system activation state, where some sorts of instigating factors, such as trauma, can work as a catalyst in genetically predisposed psoriasis patients. Then is the inflammation acceleration phase, where patients remain asymptomatic, but we can see imaging evidence of early disease. And then is the symptomatic phase. I think this is the stage where we can really intervene before patients develop clinical psoriatic arthritis, but they still have symptoms such as arthralgias, stiffness, joint fatigue, non-specific symptoms. So this study is an example. This was done in 162 psoriasis patients and some 60 age-matched controls. These patients did not meet the CASPER criteria. That means they did not have clinical evidence of psoriatic arthritis. This was done in 14 centers, and they found that about 50% of the patients had some sort of signal synovitis or enthesopathy when looked at through ultrasound. And about 10% of the patients had power Doppler signal as well. That means they had inflammation. So who are these patients whom we need to target? So this study was done in 2021, and this was a meta-analysis for all the risk factor studies. And they found that patients who are obese and those with trauma, these are the two risk factors which have the highest odds of developing psoriatic arthritis. This is looking into electronic healthcare records. This study was done in UK from 1998 to 2014. About 1,500 out of the 100,000 patients developed psoriatic arthritis. They were more females than males, and they found that higher the BMI, more was the risk of developing psoriatic arthritis. And reduction in this BMI over 10 years led to reduction of developing PSA. So is obesity, targeting obesity, the answer? There is a bidirectional relationship between metabolic dysfunction and inflammatory arthritis. We all know that chronic inflammation due to psoriasis can promote insulin resistance, adipose tissue inflammation, that in turn cause impaired incretin signaling, and that leads to amplification of IL-23 and 17-driven immune activation, which in turn leads to the clinical manifestations of psoriatic arthritis. So are GLP-1s the answers? We are all aware of both the TOGETHER studies. In TOGETHER psoriasis, patients on ixekizumab and tirzepatide had 40% more likelihood of achieving PASI 100 than ixekizumab alone. And in PSA space, the combination of ixekizumab and tirzepatide, there was 64% relative increase in proportion of patients achieving ACR 50 response. So what do we know about GLP-1s and the prevention of psoriatic arthritis? We have Dr. Liao and his group did this study looking into TriNetX database from 2005 to 2025, and they had 22,000 patients on GLP-1 and controls, and they found in about 5 years, patients on GLP-1s had a lesser odds of developing psoriatic arthritis than the controls. And these changes were seen even at 1 year. This study was published in 2019. They analyzed the effects of weight loss treatment with very low energy diet on disease activity. But these patients had already met the Casper criteria for psoriatic arthritis. And they just analyzed 41 patients. They were, again, more females. And the mean weight loss in this study, the percentage was about 20%. And larger weight loss resulted in more improvement in disease activity scores in dose-dependent manner. And you can see the figures with BSA, DAPSA, DAS28-CRP, and HAQ scores. And MDA improved from 24 to 54% in this study. So we are yet to determine if GLP-1s can truly prevent psoriatic arthritis. What about our biologic therapies? So these are a few studies that were published in 2022, 2023, again looking into electronic healthcare database, most of them done in TriNetX. And they showed that patients on biologics took longer time to develop psoriatic arthritis as compared to phototherapy, topicals, or conventional DMARDs, except the study by Mir that showed the opposite results. And the concern is that there's a lot of misclassification in these studies due to use of electronic healthcare records. And also, we are comparing apples with oranges when we are comparing patients on biologics with patients on phototherapy because of different disease activity levels. So we conducted this study hoping that we're comparing apples to apples, just patients on biologics with each other. And we found that patients on IL-23 and IL-12-23s took longer time to develop psoriatic arthritis. And these results have been replicated many times. So for preparation of today's talk, I went and looked up what is new in this field, and I found this study. This was just recently presented at AAD 2026, and it received the second place in the poster awards, and it's the same study. Looking into TriNetX, IL-23s, this table I really liked. It represents the hazard ratios, and IL-23s and 12-23s took longer time to develop psoriatic arthritis. I also liked the figures that they showed in the poster, but this is all we have. And why IL-23s? We just saw the GUIDE trial, and we also know the knockout study. I will mention it this time. Maybe T memory cells are implicated in the pathogenesis. You know, we can only, what is the significance of these EHR studies? We can only rely on them. They're only meaningful if we assume that all patients with a code for psoriasis do not develop psoriatic arthritis, and it's been completely excluded. And new PSA during this observation period has been reliably coded, which we all know is not true. So there are a couple more studies which were published within the last 2 years. This is a retrospective observational study, not by EHR. This was conducted in bio-naive psoriasis patients who stayed continuously on biologics for 6 months. They looked at 600 patients. They were a little bit more males than females. And 10% of these patients developed psoriatic arthritis. And IL-23s were the winners again. And this is the latest that we have. Again, a single center retrospective study. And they looked at patients from 2008 to 2024, and 300 patients were included. And they divided them into 3 different groups. The first group was the one on biologics, the second only conventional DMARDs, and the third with non-pharmacological treatment, which were least number of patients. And they found that the group 1 had highest risk of developing PSA. But the point that they wanted to make is overall the prevalence of PSA is reduced. It says 11.7% compared to our previous studies. So, you know, there is a chance that biologics do prevent PSA because the prevalence is much lesser than it used to be. And the factors associated with the development in their study was OSA and nail involvement. And based on all of these studies, we are not truly sure that can we prevent psoriatic arthritis. So this is not a retrospective study. There was some intervention done with ustekinumab, very small study in 2019, where 73 patients who had PASI more than 10 and 23 healthy volunteers were included. And these patients were, again, subclinical patients who did not meet the CASPA criteria. And half of these patients had at least one inflammatory lesion, some abnormality. And they found that with ustekinumab treatment, there was a significant reduction in the mean inflammation scores as early as week 24. We are all waiting for PAMPA trial. This is going to be the interventional trial. They have included patients who are at risk for developing psoriatic arthritis, and these are the patients with psoriasis duration of more than 2 years and BSA of more than 3%. And a lot of their patients are going to have a positive ultrasound score of at least more than 3.36. So the endpoints that they're looking at is changes from baseline in this ultrasound score. So these are subclinical patients who have ultrasound evidence of inflammation. And we're waiting for the endpoints where the other endpoint is the difference in proportion of patients who will develop PSA, but their timeline is just 96 weeks, which may not be enough. So far, none of these studies can prove that we can prevent psoriatic arthritis. Can we intervene? Maybe we need to go back to immunology and try and figure out if we can truly prevent the disease. This was just published, a pivotal study in this field, and they've used in vivo system to track cell migration using photoconversion. There included 20 healthy donors, 24 patients with psoriasis, and 19 with psoriatic arthritis. And they looked at the CD2, MHC2, and CCR2 positive myeloid precursor cells in circulation, skin, and synovial tissue. And they compared the abundance, and they found that these cells were found in all 3 cell lines. But in psoriatic arthritis synovium, there was reduction of percentage of these myeloid precursor cells interaction with fibroblasts. And this step happened immediately after entry into synovial tissue before development into subsidiary macrophage subsets. And the reason for this is that there was reduction in CD200 positive fibroblast cells. Maybe that is the pathogenesis. So they concluded that there is increased migration of these myeloid precursor cells, but that migration is not sufficient. There needs to be reduction in this CD200 positive fibroblasts in synovial tissue during the onset of arthritis. And these fibroblasts, they work as gatekeepers for inflammatory arthritis. And this interaction is reduced due to this number of reduction in fibroblast. So they did a little intervention in mice where antibodies to CD200 polarized precursor cells led to pro-inflammatory phenotype in vitro and also led to spreading from skin to joints even in initially arthritis-resistant mice. So maybe this is the answer, the CD200 receptor axis. Maybe this is the promising target for preventative medicine. And this is my last slide. This is the same group published this study in 2024, and I don't have a very good understanding of this study, but in mice, they treated the mice with recombinant CD200 agonist antibody, and they found that there was reduction in tracer uptake in the joints, and there was significant reduction in inflammation and damage. So maybe this is what we need to target, and that's the immune interception we need to do to prevent psoriatic arthritis. Thank you.
It's open for discussion. I might have a first question. How do you define preventing PSA? That's something I really never understood, because all these patients on the biologic, they receive a biologic therapy which is effective also for PSA. So how do you define that they're not having actually PSA which is controlled by the disease? While obviously the control group doesn't get any therapy, they develop the joint pain, stiffness and everything. So first there's a selection bias, but then again on top they're still treated. So how do you define preventing, in the clinic, preventing PSA?
In clinic preventing, maybe reduce the risk factors like obesity.
But how do you find that the patient didn't develop PSA actually, but he's just controlled?
Well, it's hard to do that, right? When patients are just controlled, and if I don't find evidence of active inflammation, I think they don't have PSA. But it's hard to actually define if there is true prevention or not. But overall, the prevalence of psoriatic arthritis, maybe it has reduced over time. We need to do larger studies to look at the prevalence and know that there's true reduction and there's true prevention or not.
Andy?
Great talk. I actually gave a very similar one at the AAD. So
Okay.
one of the criticisms that I had of my talk was that the replicative data from your study all use the same database. So that, of course, it's going to replicate because it's the same database.
Yes.
So what is your comment to that comment, number one? And then we really need a PAMPA study comparing the different MOAs, right? I mean, I don't know why 23 versus 17 versus TNF wasn't done in that study, because that's really the prospective study that we need, right? So.
Yeah. So to answer your first question, yes, that's true. All these studies were done in TriNetX database, but I also showed you another retrospective single center study that also showed that IL-23s won, maybe because IL-23s are prescribed more by dermatologists. We've shown that also. Maybe that is the reason they're winning and they're preventing the disease. To answer your second question, the PAMPA study, yes, 2 years is not enough. What we really need, we all need to get together and actually do a study to actually look at prevention and compare different biologics, or maybe compare conventional DMARDs also, right? If we treat psoriasis early, we know that worse psoriasis leads to development of psoriatic arthritis. I think any intervention at psoriasis level may be able to prevent psoriatic arthritis, but we need to prove that together.
So thanks a lot for talk. Excellent.